Introduce yourself and get us started.
Mhm. Hi, my name is Ann Marie, and this is Roxy right here. I'm a hospitalist at UNC and excited to present a case I saw fairly recently on the wards, and Roxy is excited to get cuddles. So I think that it would make sense to just kind of start from the labs, but if you all want, I can give a little bit of clinical context.
Could we just have a one-liner maybe?
Yeah, so this is a 30-something-year-old male with a history of vasculitis presenting with worsening pain from digital ischemia.
Are these the actual labs that are
They
up?
are the actual labs.
Good. So, Josh, why don't you introduce yourself first and go first, and then we'll go ahead and let Natasha follow up. So she's your upper level today.
Everybody,
I'm getting you, Natasha. I'm getting you prepared to be an upper level.
I'm Josh. I'm a fourth-year med student up here in Austin, who's very happy to have power, water, and gas compared to last Tuesday. It was quite real in Texas. Yeah, applying med peds, and outside of medicine, I like yoga and running.
Okay, so Josh, tell me what your thoughts are about these numbers.
Okay, so just going sort of top to bottom on the fishbone, the first thing I noticed is hypokalemia, but sort of low normal chloride, low normal sodium, metabolic alkalosis, and then a low BUN and creatinine, possibly low depending on what this person looks like, and sort of what their previous BUN and creatinines have been, and a normal glucose. So to name the problems, it looks like a hypokalemia and a metabolic alkalosis.
Okay. Do you have anything to add to that, Natasha?
Not a lot. Other than I was just wonder for past medical history, like exactly what the vasculitis is. Because that's a pretty broad term, but I agree with everything Josh has said so far. Those are the things that jump out to me.
Okay, first of all, I'm gonna say that even though the sodium is 135, which is not really very low, that's another clue to me that there's inflammation going on. Even though it's mild, very mild hyponatremia, I'm not gonna do anything about it. It makes sense in someone who's somewhat sick, because pain is one of the things that releases ADH. And so you get mild hyponatremia. That's just consistent. The anion gap is normal. We had to check that. We're not 100% sure it's a metabolic alkalosis unless we get VBG. Now, we can probably deduce that it is. Hypokalemia, as many of you know, is one of my favorite things. And I like to think of hypokalemia in 3 buckets. And the buckets are based upon the acid-base status. So it might be, why don't we go over those buckets, and then we'll settle on the bucket that we actually have. But someone comes in and has hypokalemic normal gap metabolic acidosis. What are you thinking about, Natasha?
The first thing I usually think of is losses. So are they having diarrhea, or are they on some medication? Because multiple medications, especially first thing I would think of is diuretics, cause hypokalemia. Or is it something hypokalemia?
So I'm gonna play off what you say. We're gonna have a lot of interaction here. 100% right on the diarrhea. That's a possibility. Diuretics are going to cause a metabolic alkalosis. They're not going to cause a normal gap acidosis. So just sticking to the normal gap acidosis, we have diarrhea. What else do we have?
A normal gap acidosis.
Yeah, normal gap acidosis and hypokalemia. Good. You look a little bit uncomfortable, which means learning is about to occur. Josh, do you know where I'm going?
Either aldosterone excess or an RTA.
So aldosterone excess is going to be we're going to get to when we get back to metabolic alkalosis.
Oh, then an RTA. Yeah.
So, and which RTAs will do it?
Proximal and distal.
Correct. And which one is more likely to do it of those two?
I do not remember the difference.
Yeah. So distal RTA is the one that you'll see on boards of someone who comes in with sudden onset of quadriparesis because they get such low hypokalemia. And Kushal, don't look at the chat. Kushal named the thing that is most common to cause that distal RTA. This is just a pimp question, but it's a pimp question that ends up on tests. So, and it's actually sort of worthwhile to know. And I'll give you a clue. Sean Carter thinks it's cool.
Something rheumatologic.
It is rheumatologic.
I'm gonna guess either lupus or like scleroderma renal crisis.
You can get it from lupus, but it's most commonly associated with Sjogren's. So there's an overlap with lupus because some people with lupus also have Sjogren's, but that'd be the classic case that you'd see in the literature for hypokalemia and normal gap acidosis, severe hypokalemia. For some reason, it gives you very, very severe hypokalemia.
What in
Okay.
Sjogren's causes that?
How does it do it? I do not know.
Okay.
You see, the clinical problem solvers would be proud of me. I just said I don't know. It must do something. So we're getting some links. I think it must do something to the tight junctions that you have between the distal tubule. I don't really know why.
Okay. We'll look it up for next
Why do they
week.
get it? Because they lose the ability to block the flow of hydrogen ion potassium. And so what is the, how do you diagnose a distal RTA?
Urine studies, like the electrolytes and pH.
What about the pH?
It's basic.
Right, it's the inability to acidify the urine. And if you can't acidify the urine, then you can't handle the acid that you eat every day, because we eat about 1 milliequivalent per kilogram of acid per day. And we have to buffer it with phosphates, and we have to also buffer it with ammonia. Ammonia only works if you acidify the urine. And that must have something to do with the reason they get so hypokalemic. But this patient doesn't have that. What if the patient came in and had quadriparesis and a absolutely stone cold normal venous blood gas, a normal bicarb, but severe hypokalemia, and had quadriparesis? So the first bucket is the acidosis. So this patient doesn't have it, but severe diarrhea could do this distal RTA, less commonly proximal RTA.
The hypokalemic periodic paralysis.
Right. More common in certain ethnic groups, and more common associated with hyperthyroidism. This patient doesn't have that. So this patient has hypokalemic metabolic alkalosis. Do we happen to have a VBG by any chance, Ann Marie? You're muted.
We do. Let me pull it up.
Let's pull that up
So
just because that's really the first step. Let's make sure that's what we're really dealing with.
So the BBG shows a pH of 7.41, a PCO2 of 48, and then calculated bicarbonate of 30.
So that's really interesting, isn't it? That's really interesting. So it looks like this is what's tricky. The respiratory the respiratory acid-base disorders, the kidney can often totally compensate for those. That's especially with respiratory alkalosis. Now, this looks like a respiratory acidosis and a metabolic alkalosis. It's hard to say which one's which, and whether the hypokalemia, is this really a metabolic alkalosis, or there's something weird going on with a CO2 of 48 in a 30-year-old. So I'm sort of interested in the vasculitis. Worsening pain from digital ischemia. There's a thought that keeps going through my mind. Have you ever seen anyone who had to have fingers amputated? So, Josh, why did you see someone who had to have fingers amputated from some type of a vasculitis?
Or not from a vasculitis.
Yeah, not from trauma.
No, it was just really bad PAD.
Okay. Did they also have to have toes amputated?
Yeah, they did.
Okay. What if you just saw fingers amputated? Because I actually had this patient. A patient who over and over again had to have more and more fingers amputated. His toes were perfectly fine. And they're very painful.
Berger disease?
He had Berger's disease, yeah. What is Berger's disease?
Associated with like a vasospasm of the small arterioles in the hands.
Caused by?
Cigarettes?
Nicotine. And it's important to remember that it's nicotine, because you can't give, if they want to stop smoking, you can't give them nicotine supplements. And is Sukriti on here by any chance today? Okay, why would she be more likely to see this than we would be? Does anybody know? Why is burgers more common in India than in the US?
Is it the chewing tobacco that's like a big part of the cultural phenomenon there?
So it's the way they roll their cigarettes. They're called beedies, and they have very high nicotine levels. They're cheaper and very expensive. But now let's get back to our case, because I do ramble, but rambling is fun. Okay, let's just for the sake of education, let's think about what causes a hypokalemic metabolic alkalosis. This might be that, it might not be that, and we're going to have to go back and think of why this patient has a high PCO2 here in a few minutes. But how do we work up a hypokalemic metabolic alkalosis? Do you know, Natasha? What's the next test you want to order?
I'm remembering something about urine studies, including a urine chloride.
That's exactly right. That's positive feedback, by the way. So a urine chloride is going to distinguish between saline responsive and saline unresponsive. So let's think of the saline responsive hypokalemic metabolic alkaloses, and let's think of the saline non-responsive, and then we'll get the urine chloride and see which bucket it might be going in. We're a little bit unclear because the blood gas has us a little confused. So if it's a low urine chloride, and low usually means less than 20, then it's going to be saline responsive. If it's high, then saline's not going to fix it. Okay, so what are the saline responsive? You already gave me one of the saline responsive causes.
Diarrhea.
No, diarrhea causes an acidosis.
Oh, right. Sorry.
What I think Josh said it. Do you remember what you said, Josh? One of you said it.
Is it diuretics?
Diuretics, yeah, diuretics. So diuretics will do it. What else? What's the most common reason for hypokalemic metabolic alkalosis in the hospital?
Vomiting? No.
Vomiting, yeah. Vomiting or gastric suction. Losing acid from above. So we got to get that history. Has this pain caused nausea and vomiting? Is this patient on diuretics? Volume contraction in and of itself could do it. So if we think this guy's volume contracted, what's against it being volume contracted is BUN and creatinine are really probably totally normal for a 30-year-old guy. His BUN is not that low. I mean, it's normal, but it's not ridiculously low, and it's not ridiculously high like you'd expect with volume contraction. And that's not perfect. He still could be a little bit volume contracted. We'll have to go back and examine him. Okay, what are the saline non-responsive causes? What's the poster child for hypokalemic metabolic alkalosis? Aldosterone. Okay, so any way that you have increased aldo can do this. So aldosteronism, secondary aldosteronism. So patients with cirrhosis will often get hypokalemic metabolic alkalosis because they have secondary hyperaldosteronism. And then the candy man is in the chat, right? What candy is in the chat?
Licorice. I saw that earlier.
Licorice, right? Glyceric acid. So you can get it from licorice. You can get it from licorice oil. Some people will go to health food stores and get licorice oil. You can get it from chewing tobacco in the United States. I think Red Man particularly is flavored with it. So people who swallow their chewing tobacco can get this. And then there are a bunch of things that let's see who has this. Travis had a big list. So the next thing we want to know is we really want to know the vital signs in this patient. Are we dealing with a hypertensive patient or a hypotensive patient?
Okay, so as far as the vital signs, the heart rate was like in the mid 80s to 90s, and then the blood pressure was in systolics in the 150s to 160s, and diastolics around 100 to 110. Notably, for the blood pressure, or for the digital ischemia, had been started on sildenafil, which had been up titrated, as well as nifedipine, which had been up titrated, still with pretty significant hypertension, but otherwise did not come in on any medications.
So had the patient been hypertensive before?
So looking through the outpatient notes, it looks like there had been some long-standing hypertension, like systolics between the 140s and 50s, 160s, but had not previously been on medications or hadn't previously been addressed.
Okay, so somebody's gonna have to help me here. Sildenafil, I think of for pulmonary artery hypertension, and I just don't know all the other vasculitic reasons that we'd use it. Sean, can you help me since you're going into rheumatology?
Maybe a little bit. It can be helpful with digital ischemia, like Travis is talking about, and in Raynaud's just in general. So it'll be interesting, I think, to kind of hear a little bit more about this patient.
Yeah, because if it's for pulmonary hypertension, then we might be able to explain that elevated PCO2. We don't know what size this patient is. In the vital signs, you didn't give us the weight or the BMI. You're muted, Anne Marie.
The BMI was around 30.
Around 30. I guess he could have, you could have obstructive sleep apnea. So I guess we need to know, what is this vasculitis that's causing digital ischemia? So how long has this vasculitis been going on?
So he had about a 5 to 6 months history of vasculitis. It was presumed to be secondary to EGPA. The ANCA was negative, but there was significant eosinophilia. The vasculitis manifestations were CNS manifestations. There were never renal manifestations prior. And then over the past month had developed this progressive ischemia of the digit, but it was felt that other markers such as CRP had been downtrending, eosinophilia had been downtrending, and so it was felt to be more of a chronic sequelae. Notably, he was a smoker, but had stopped smoking a few weeks prior, and just regular cigarettes.
So I have seen smokers who had burgers, and every time you see digital ischemia, you actually have to have that in the back of your mind. That's probably not what's going on here if he stopped smoking. But I mean, it's certainly a possibility. Has he been on steroids for the eosinophilia?
Yeah, so he was started on given cyclophosphamide, and then started on high dose steroids, which has been progressively tapered down from a dose of like 60 now to a dose of 20 milligrams, and is also on azathioprine as well.
Is it prednisone?
Yes, prednisone 20 milligrams.
Okay, so could prednisone cause the acid base? Is there enough mineralocorticoid activity in prednisone to do this? I think it could. Do we have a urine chloride?
So no urine chloride. I'm so sorry, but was previously no like GI losses, no vomiting, no diarrhea, a little bit of port intake secondary to pain, but was eating pretty well. Given a trial of normal saline, and the symptoms did not, and the like labs did not resolve with that.
Right. So, you know, when I talk about getting a urine chloride, that's what should be everybody's first instinct, but many physicians don't have that instinct, because you don't see hypokalemic metabolic alkalosis that much, and most people aren't really hypokalemic nerds like I am. So I get real excited, and I would just get the urine chloride. I wouldn't get anything else, because the urine chloride is really the answer. So not on a lot of prednisone. So what do we think about this PCO2?
I'm puzzled by it. I would have thought he would have had a bit of a respiratory alkalosis if he was in pain. But otherwise, I mean, it could be attempting to compensate, though I don't think the bicarb and the rise in the PCO2 are, I don't think the math works out on that one.
Can someone look up the compensation for metabolic alkalosis? I think this is overcompensated. That's just my gut feeling, but I don't remember this one. So if someone has MD Calc and can plug it in and see if this is compensation or not. Is this appropriate compensation? Anybody find it? Okay, 40 plus 0.6 times the delta of bicarb. So the bicarb, I guess we could say normal is 26, so 0.63 43. So this is a higher CO2 than we would expect. Did everybody get that math that I just did? So pulse ox. So this is a VBG, right?
It is a VBG with saturating between like 96 and 98% on room air, and no signs of sedation or anything like that.
Okay. So where are we going to go from here, Natasha?
I guess I want to know why he's breathing fast. So with
He's breathing slow. Well,
sorry,
he's
why
hypoventilating.
he's not blowing off carbon dioxide.
Yeah, just
Why he's
because
overcompensating.
just because this is I say this over and over again, but I say it over and over again because people forget this. Tachypnea does not equal hyperventilation. Slow normal rates are not hypoventilation. Hypoventilation is an increased PCO2. That's actually the definition of hypoventilation, as an increased PCO2. That can be caused by decreased tidal volume or decreased rate. So if I give you an opiate and you're only breathing 8 times a minute, you might have hypoventilation with a normal tidal volume. Then there are other people, because of their lungs, they really can't move much air. And even though they're breathing at 20 times a minute and pursed lips, they still are retaining CO2. So we have to dissociate the idea of the speed of breathing with ventilation. And this is hypoventilation by definition. Why do people get hypoventilation?
His BMI is 30, but I would think about like obesity, hypoventilation syndrome. It's certainly possible, but would not be the highest on my differential.
That's what we see we see that all the time. And what else do we see all the time?
Sleep apnea.
Well, that's sleep apnea. So sleep apnea, and there's another disease we see all the time. Now these people come in with bicarbs of 36, but CO2s of 50 or 56 or something. COPD. Now you can get it with non-obstructive chronic lung disease, but it's most common in COPD, especially in chronic bronchitis. But he should have a low pulse ox in that situation, right?
Mm-hmm.
And he should have a low pulse ox if he has obstructive sleep apnea. So that's what has me confused as to what is going on here with the PCO2. Is this guy? People want to know: is this guy a smoker? Ann Marie.
So he was a former smoker, but he quit a few weeks ago, but not a significant pack year, around like I think a 5 to 10 pack year history total.
Okay, so that doesn't make sense for COPD, and his pulse ox is too good for COPD, I think, not for emphysema, not for asthma, but for chronic bronchitis, who's most likely to get CO2 retention. I might repeat it one more time and just make sure it's not a lab error. By any chance, did you repeat it?
He did not get a repeat VBG.
Okay. It's just a strange number, and I'm trying to figure out how to put it together. What about, let's what other history do we want? So we know he has, we assume he has EGPA, right? Eosinophilic granulomatosis with polyangiitis. He's had CNS problems. I guess CNS problems can cause hypoventilation, right? Depending upon where it is in the brain. And so now I'm going to have to go back and look at his brain films and go talk to a neurologist and a neuroradiologist and see whether or not that could be causing enough hypoventilation to cause the respiratory acidosis part, in addition to the hypokalemic metabolic alkalosis.
Yeah, so he was requiring some opioid pain medications, and while he wasn't sedated from that, the thought was it was like an early morning BBG. There was some concern that there might be some sleep apnea, and had gotten like some pain medications. So kind of thought that some of that hypoventilation might have just been kind of a mixture of all those things.
So we're going to find out, does he have a licorice habit? Does he chew tobacco and swallow stuff? And then I don't know how else to work him up other than do we have previous do we have previous basic metabolic panels that were normal? This is a change? And how recently did we have one? And was it when he was on prednisone?
Yeah, so we actually had basic metabolic panels when he was on higher doses of prednisone. We had one from like about a month past, and the potassium was normal then. And so this was like a significant change in the last month, although he had been on lower doses of prednisone than previously.
Okay, are these all his medicines? Sildenafil, nifedipine, cyclophosphamide, prednisone, azathioprine?
Yeah, he was getting like some pain medications as needed, oxycodone for the significant pain from digital ischemia, some Tylenol, and then some prophylaxis with Lovenox, or enoxaparin, I should say, but otherwise no other medications.
Okay, so we have hypertension. Does he stay hypertensive when he gets his opiates? Does his blood pressure come down?
It persisted despite pain medications and trying to get better pain control. It kind of just in the systolic 150s to 160s, despite the fact that the sildenafil and nifedipine had recently been up titrated.
Okay, and this is new hypertension.
He had had some like borderline hypertension on past clinic visits that had just never been worked up. We looked back and it was like kind of in the systolic 140s to 160 ranges on some of his clinic visits, and it just hadn't really been, it appeared, ever addressed kind of prior.
Okay, so
but it seemed a little bit more significant, especially since he had started these 2 new medications and his prednisone dose had actually come down significantly.
So Josh, let's go back to how we would work up new hypertension unexpected in a 30-something-year-old. And because there's some hypokalemia, it's probably worthwhile to work them up. So what are the big diagnoses that we have to think about in somebody in their 30s? And I just had a thought of something. We'll see if y'all come up with it.
The first things that come to mind for me are something like a pheochromocytoma, hyperaldosteronism,
right.
Renal artery stenosis.
Okay. Why might he have renal artery stenosis?
He's got resistant hypertension despite being on 2 medications.
Okay. No, but what would be the cause? Why do 30-year-olds get renal artery stenosis?
Oh, I think it's fibromuscular dysplasia.
Right, and it's more common in women.
Mm-hmm.
Okay, if I got it at my age, what would be the cause?
Cancer?
No. I'm certainly at risk for cancer, but I don't think it's going to cause renal artery stenosis. Natasha, why would I get renal artery stenosis?
That's from atherosclerosis over time.
Atherosclerosis. I haven't seen it before, but he has something else that probably could cause renal artery stenosis, or at least functional renal artery stenosis.
The vasculitis?
Yeah, could the vasculitis be affecting his renal arteries? And if it did, could that give you these numbers? And I think you can get a hypokalemic metabolic alkalosis because it's sort of a pre-renal type thing. because you're not getting enough blood to the kidneys. So aldo gets excreted, stuff like that. So it'd probably be worthwhile to get aldo levels if we can get them, and renin levels, but also would be very interesting to do renal ultrasound, or to do, because he has great kidney function, even do a CTA to see what the extent is of his vasculitis. He has this really bad vasculitis right now. We know that it's that he has digital vasculitis, but we don't know where else it might be. And given the hypertension, I think I'd try to track that down. Does that make sense? Have I gotten too weird on this one?
And is lupus always a possibility here too?
I think so. I mean, it's presumed eGPA, but presumed means maybe it could be something else. And
So
lupus
did
can do
get
all
a
kinds of weird
pretty-
things.
I
What?
did get a pretty extensive autoimmune workup in the past that was unremarkable.
Okay.
So
So
negative.
they look for
AA.
lupus hard.
Mhm.
So can you give us an aldo level?
Yeah, I can do that. So the aldosterone level was 49. Do
You have to
want
tell
any?
me.
Do you
You
want
have to
any
tell me what
other
the
levels?
normals are.
So the norm. Let me look it up really quickly. That is abnormal, but I'd
Yeah.
have to so normal is less than 21, and there's some notes.
Okay.
This was an afternoon collection, and reference range for upright AM collection. And so that's like the reference range for AM collection. So like the fact that it's afternoon
Yeah.
could have affected it a little bit, but
Not 49.
Yeah.
Okay, so we have increased aldo. Now, the renin is going to help us. So is this because of renin or despite renin? So if the renin is low, then we're going to say it's primary aldosteronism. If the renin is high, then I'm going to look for the renal artery arteritis.
Mhm.
Does that make
So
sense to everybody?
The renin level was 150, which is normal is the mean is 10.8 and the range is from 2.9 to 24.
So we got massive stimulation of renin and aldo. So Hassan, I like that. Maybe it's a reninoma. It could be a reninoma, but do we have an ultrasound or a CTA?
Yeah, so renal ultrasound with Doppler did not show any obvious stenosis. The renal, the kidneys were normal, and then there were no flow abnormalities on that.
I still might do a CT angio.
Yeah. So kind of the story of this, and it's a little bit kind of a case that might leave you hanging a little bit. So briefly, I'm taking care of him, had sent the workup, it wasn't back, ended up kind of for various reasons, which I will not go into, switching to another service, and then was discharged from that service. And so I kind of I was no longer taking care of him. And so the levels came back, and was kind of discussing with the outpatient team, but did not end up getting further abdominal imaging. But his outpatient team is aware, was started on spironolactone with improvement of, but not complete resolution of the hypokalemia. So it's kind of still ongoing, and I don't have 100% answers, but I thought it was really interesting. We didn't talk about his urine stuff. There was no obvious involvement of his renal involvement of the vasculitis, but interestingly, like his urine potassium was really high, and if you calculated a and there was like pretty significant signs of renal potassium wasting. So there was something amiss going on that was driving this elevated renin, and I'm not exactly sure what that was.
Yeah, so I think it would be fascinating to see if it's bilateral or unilateral. So I, I would probably get together with my friendly endocrinologist and see whether or not it's worthwhile to sample the renal veins and see if there's a difference between the renal veins. And the question then is there vasculitis affecting one kidney, or is there vasculitis affecting both kidneys, or are we totally off base?
Mhm.
But I'm still concerned about the possibility of
Yeah.
vasculitis, even with the. I don't think the ultrasound is perfect for that.
Yeah, that's how I felt too, and kind of how I communicated with some outpatient providers who were going to be following up kind of about the findings and everything. And but I don't have a 100% answer because of that. I was doing some reading, and reninomas in themselves are like just exceedingly rare. So I felt more likely that this was some manifestation of the vasculitis that was driving the elevated renin, which in turn was driving the elevated aldosterone levels. But I don't know exactly what that manifestation was.
So it would have been fun to, when he was off opiates, to get a blood gas and prove to ourselves that the PCO2 was that. The renin and aldo really say that it's secondary hyperaldosteronism,
Mhm.
and the question is, what's the cause of the secondary? Some wonderful comments in the chat. So Josh, you get to be first, and tell me your take home points from this and what you learned tonight.
So hypokalemia in the setting of metabolic alkalosis isn't something that I had spent too much time thinking about. And so I think when I see hypokalemia in the future, I need to pay attention to whether it is an acidosis or an alkalosis, because that will send me down two totally different paths.
Yeah, and you're going to see it when you're an intern. I promise you're going to see it when you're an intern. Natasha, you are an intern.
I am. I
She's a
can't
darn
say
good intern also, by the way. I did work with her for a week, and she's very good.
Thank you. I agree with what Josh said. I feel like when I came into residency, I was very anxious about hyponatremia, but now I feel like I have a really good algorithm for that. I don't feel like I'm quite there yet with hypokalemia. This is a really good starting point. And then just a good review on saline responsive versus non-responsive alkalosis. I think the first time I ever even heard about getting a urine chloride was on one of the episodes of this. So I wouldn't have gotten that right if I hadn't been watching. So that's a plug for unRemarkable Labs. And then just always paying like close attention and not just ignoring, or, with the BMP, it can give you a lot of information.
I get very excited about BMPs.
Yeah, and I have to say, after working with you, I have been too. I had a patient with a low bicarb yesterday, and it reminded me of that patient that we admitted who we thought was tachypnic because of his heart failure, but it turned out that he just needed bicarb and that he was actually breathing fast because he's compensating. But yeah.
I'm trying to recall the thought that I just had about this. Oh, the transtubular potassium gradient, because you brought it up, Ann Marie. The renal community is not as excited about that as it once was. Some of you've heard me say this before. When I was taught this specifically about people with cirrhosis. So people with cirrhosis have secondary hyperaldo. And the way that I was taught to convince myself of that is to find out they have a low urine sodium and a high urine potassium. That's an aldo effect. And I don't need anything more than that. And then when I'm treating secondary hyperaldo, this goes back to part of the conversation we had with Brooks Vaughn. I keep increasing the spironolactone until the urine sodium is higher than the urine potassium. So before I ever start a loop diuretic in someone who has cirrhosis and ascites, I titrate the spironolactone to make sure that we're not going to be peeing out potassium all the time. And so in this patient, what I would have done, Ann Marie, is give enough spironolactone so that the urine potassium was less than the urine sodium, and that should fix the acid base problem. It might also fix the hypertension, but it's a fascinating case. What are your big take-home points? What did you want everybody to get out of this, Ann Marie? Because is a really fun case.
Yeah, so I just thought it was interesting in that like we saw this abnormality and just like stopping to kind of pay attention and how much just the low potassium with the high bicarb and the VPG was kind of weird. It did kind of, we were like, why is this metabolic acidosis here? But with transfer and everything, we didn't end up like rechecking it, but just like kind of paying attention to the abnormalities that you see on labs and trying to address and pursue them and like really think about what's going on, because we kind of were looking at it and we're like, well, he's not having GI losses, not on diuretics, and this is kind of new and different. Like we think it's related to the renin-aldo system and like maybe possibly to his vasculitis. And so just like kind of taking the time to think through that and, try to pursue the abnormal labs and think about what could be at play.
Did you do in your research, were you able to find cases of renal arteritis that would lead to this?
Well, it's not too much, but it seems like possible that like a vasculitis could cause it, like some sort of like infarction. I mean, certainly with the digital ischemia, it seemed possible that could be at play.
And Sean, you get the last word, unless I decide to take the last word, but maybe you get the last word.
I think you always get the last word as kind of the contract agreement. So I think the thing that's really interesting to me about this case is kind of looking back in the past to see that, hey, he did have the normal potassium on a higher prednisone, which is pretty interesting. And I think that helps lead you down the road that he ultimately led to a partial diagnosis. So, I mean, it's true in cardiology. What did the EKG look before? What did the UA look like before? Just over and over again. What's the patient's baseline? And is this a change? If so, why?
Sounds great. Okay, we got some good stuff coming up for March. We haven't decided exactly on the case for next week. I can tell you the third week of March is going to be at 6 p.m. It's going to be Jory May discussing a patient that I took care of in the hospital last month, and it'll be very, very educational.